Hi everyone, Vicky here from Brain Injury Hawke's Bay. Welcome to our Community Collaborators Brain Talk series. Today I'll be talking to Steve from Proactive Health. Thank you so much for joining us, Steve. Could you start by telling us about your role at Proactive and what you're going to be talking to us about today?
Physiotherapist there and been treating concussion clients now for almost 10 years. What I talked to you today about was the neck, the ocular or visual systems, and the vestibular system, or your balance in where your ears are. But just to start off, the neck and the vestibular and the visual systems are a very appropriate area for the physiotherapist to be treating. And what we tend to see after a concussion is a lot of concussion symptoms will have people reporting them feeling unwell, nauseous, dizzy, spinning sensation, headaches, and very tired. And what's happening is these three systems, your neck, your visual, and your vestibular balance systems, would normally be telling your brain that everything's all lined up and all good. But what happens after a concussion is one of those systems, or maybe all three of them, have been affected to the point that the brain isn't able to match things up. And what the eyes is telling the brain, and what the ears balance is telling the brain, and what the neck, muscles, ligaments, joints are telling the brain don't match up anymore. And so that mismatch of information then confuses the brain and can start people having symptoms of feeling dizzy, nauseous, headache, etc. So physiotherapists who's experienced in the concussion area will look at these three areas and try and determine, are they working properly, and go through various tests to determine if that's the case. And depending on what they find, if there's issues with neck issues, visual issues, or vestibular balance issues, then they'll go and address those problems specifically. Off with the neck. The neck obviously is pretty important. That's what connects your head to the rest of your body, and its job is to stabilize and keep the head in good alignment. The muscles, ligaments, joints, they're all heavily innervated and are constantly giving information to the brain about where you are in space and when you're moving, etc. So after you've had an injury to those structures, then the brain might be getting this faulty information. So some of the signs in a concussion that someone's got a neck injury would be obviously neck pain. And you don't necessarily have to hit your head to suffer a concussion. A whiplash-like accident, like in a car accident, or falling heavily or slipping heavily, the sudden movement of your head being forced in one direction and the muscles around your neck trying to prevent that movement can strain the muscles in your neck, all the ligaments, tendons, joints, and as a result give you pain. You don't even have to hit your head. Interesting thing now is there's a lot of research going on why are neck problems and neck injuries giving similar symptoms to a head injury, a concussion injury. And there's obviously lots of information traveling up and down the spinal cord and the brain stem into the brain, and from the nerves going into the neck in that area. And there's areas in the brain stem in the brain where all that information has been collated together and being passed around various parts of the brain. And so they think this information is all being gathered up in that part of the neck and the brain stem. And as a result, you can get some quite unusual symptoms of headaches and dizziness and blurred vision and fatigue, where it would be considered a fairly minor injury to the neck. So they're doing a lot of research in that, and it's quite interesting to see what's going on. Other signs and symptoms, not just neck pain, as I've already mentioned, you might get headaches. You also might find that your vision seems to be a bit affected. Coming from the neck seems a bit unusual, but as I said before, they're doing research into why this is happening. Dizziness as well. There's lots of nerves in the muscles in the neck, and it's also into the joints, and they're giving the brain lots of information about where your head is in space. And if the head's not getting that, if the brain's not getting that information, then the brain's not happy, and it can let you know that by giving you symptoms of dizziness, nausea, headaches, etc. One of the first things a physiotherapist would need to do if you're presenting after having a concussion, some sort of head or neck injury, is we need to check that there's no what we call red flags, and that's serious stuff. What we're looking at there is numbness, pins and needles, tingling in your hands or feet, or your face, difficulty swallowing, difficulty talking, numbness of the face. So the physiotherapist will be clearing that to make sure that there's nothing sinister going on with respect to the neck. What we're looking at particularly is stability around the ligaments C1, that's the first cervical vertebra of your neck, and attachments to the skull. Instability there, ligament tears or even fractures would then be possibly giving people symptoms of severe pins and needles, tingling, that sort of thing. Generally, if you've been to A&E after an accident, if they have any suspicions of these problems, these red flags, they will do an X-ray or a CT scan, and the physiotherapist will be checking to make sure those have been done. But if that hasn't been the case, then something the physiotherapist will be testing for, called ligament instability. The next thing that the physio will go on to after they've checked the stability of the ligaments around the top part of the neck is actually your range of movement, and that's very obvious. We just get people to look in different directions, side to side, up and down, and just monitoring their responses if there's any pain or loss of range of movement, which could indicate muscle or joint injury. We can then move on to checking the strength of the neck, and there's some muscles that are called the deep neck flexor muscles that have been shown in research to have quite an important role in stabilizing the head on the neck, and we do test to see if there's good strength there. Often we'll find that a lot of people are weak in these muscles, and so treatment will focus on getting those muscles stronger. There is research showing that the strength of the deep neck flexors does influence the likelihood of concussion. If your neck flexors are stronger, then you're less likely to suffer concussion symptoms. A good example of that would be like an All Black forward, or the sports people like soccer players or motorsport drivers, where they're subjecting their body, their neck, head to huge forces and are able to carry on playing week after week and competing in their sports. While general Joe public, if we were to experience what they do, hitting balls or taking a tackle or driving at speed, we'd likely find we're going to have symptoms of headaches, dizziness, sore neck, that sort of thing. So that's an important area to look at. Also, the deep neck flexor strength has been known to help manage headaches. After we've done the range of movement and the strength of the neck, we then will tend to look at palpating the muscles around the neck. There's a lot of muscles around the neck, and some of those muscles are well known to refer pain into other areas. So a common muscle that we look at is something called sternocleidomastoid, which is a big ropey strap-like muscle on the front side of your neck. And when you turn your neck, you can see it sort of pop up. That muscle is a very important one for maintaining stability of your head. And in an accident, if it's strained or pulled, it can be very painful, and weeks, months later, it can be giving people headache-like symptoms, particularly around the temple, the eye, and the ear. Other muscles are the trapezius muscles that go up the back of the shoulder up into the neck, and tender spots there, or trigger points as they're called, can also refer pain into the top of the head. The muscles right at the base of the skull that connect your skull to your neck, called the suboccipitals, tenderness there can also cause like a pressure-like symptoms around a band around the head and the eyes. So the physiotherapists experienced in those areas will know the sort of referral patterns of those muscles, and depending on what the concussion client reports the headache symptoms are, might be able to direct them to those muscles and see if they're involved. Then we also would do assessment of what we call the upper cervical spine, the range of movement there. And the physiotherapist will usually get the person laying down and lift their head up and rotate the head. They're not doing a manipulation, they're not going to crack the neck, but what they're looking for is to see that there's good movement to the left and right. And often you'll find that one side is definitely restricted, and again, physiotherapists can do a specific treatment for that, and it can help a lot with managing or resolving headache, pain, and improving neck range of movement. So that's just a very quick overview of what we can do for the neck, or assessment wise. Treatment will basically be aimed at addressing any of those problems that we found. So if we're finding that there's lack of movement in the neck, we'll be giving the person stretches to do for their neck, massage and hot packs. Heat is often useful as well to help relieve any muscle spasm and tension. The physiotherapist also can do some manual therapy techniques using their hands to try and help increase range and movement of the neck. And then any localized tenderness in the neck, again, will be managed with headaches, with massage, stretching, and even some light exercise to help relax muscles. The deep neck flex exercises specifically are given to strengthen the neck, and that exercise is very simple, involves a person laying down on their back, tucking their chin into their chest, and then just lifting the head slightly off the table while maintaining their chin tucked in. And average for a person should be about 60 seconds. So if a person's struggling to do 60 seconds, they've usually got weakness there and they need to just practice that day to day to try and improve their strength. Also, one of the important things is posture education. In this day and age, a lot of people, when they're not exercising, they're on their devices, on their cell phones, and laptops, tablets, watching TV, or just reading. And those forced postures for prolonged periods of time will put stress on the muscles that support the head and the neck. And so good postural awareness is another area that physiotherapists will be addressing, and making sure that people are sitting in correct posture and getting up and moving frequently is the important thing we get people to do. No one can sustain a prolonged posture for a long period of time. It doesn't matter how well they're supported ergonomically with correct chairs and everything, working at the computer. The best advice is to stop, have a break every half hour, get up and move around. Now is the vestibular apparatus, and this is located in your inner ears, helping you with balance. Best way to think of the vestibular apparatus is there's two little gyroscopes in your head, one in the left ear and one in the right ear. And both those gyroscopes are telling the brain where you are in space, and they should both be telling the brain the same thing. So if one of those gyroscopes is out, then the brain's getting confusing or mixed messages, and it's not happy with that. And as a result of that, it could be giving symptoms of nausea, dizziness, headaches, and fatigue. Now, one of the most common vestibular problems that we're likely to see with concussion is something called benign paroxysmal positional vertigo. And this is to do with debris, crystals, calcium carbonate crystals in the inner ear that can be lodged in the semicircular canals of the inner ear. Each vestibular apparatus has 3 semicircular canals, and they're orientated in the 3 planes of space. Generally, the most common canal that you're going to get debris in is something called the posterior canal. And symptoms of vestibular involvement of the BPVs is people feel like they're spinning or the world is moving around them. Different from being light-headed or dizzy. Generally, the spinning will come on with movement, and the most common movements are laying down in bed, rolling over in bed, and sometimes looking up or looking down, like to put your shoes and socks on or put your head back up to wash your hair. And what people will report is they do those movements and they get the sensation that the room is spinning. Some people feel like they're drunk or on a ship, and they have this movement sensation. And what they all tend to do is they stop the movement that they're doing and they wait, and then usually less than a minute, which is actually a long time, the sensation of spinning will stop. And if that's what they're reporting, we're suspecting that they've got this thing called benign paroxysmal positional vertigo, or BPPV for short. And there's some good tests that we can do for that, and also very effective treatment. The likelihood of this BPV occurring in concussion, in my experience, probably about 10%. So it's not actually common, but it's something that definitely needs to be checked on, because if it's missed, it doesn't matter what else you do, treating the neck, treating the eyes, balance, etc. Until that's resolved, the person's going to have ongoing symptoms. And the symptoms can be pretty nasty, from actually throwing up, not being able to stand up at one end of the scale, to just feeling off, not right. People talk about a thick head or a woolly head and just not comfortable moving around. They just feel that a little bit off, but hard to describe. So it can be very extreme to quite minor, and the symptoms, as I said, can be quite severe. So a physiotherapist who's assessing for concussion usually would need to have what we call vestibular training, a particular area of interest, or training in that particular role. And what we do is something called a Dix Hallpike test, and you can easily go online and check this out. But what it involves is having the client sit on a table. We get them to rotate their head about 45 degrees to, say, the left, and then we just get them to lay down, not fast. They can just lay down like they normally lay down in bed, but the head has to be tilted backwards about 20 degrees. So in the physio clinic, we'll often do it off the edge of a treatment table, but at home you could do that easily over the edge of just a plain old pillow, just have your head tilted off the back of the pillow. Now, for anybody who would do this, who doesn't have BPV, nothing should happen. You should be able to lay back, keep your eyes open, and absolutely nothing happens. You stay there for a good 20 to 30 seconds, wait to make sure nothing's happening, and then you sit up. So a negative test is, like I said, nothing happens. A positive test will be when the person goes to lay down, or once they're down there, they will often report the feeling that things are spinning or moving. Sometimes it's immediately as soon as they lay down, and sometimes it can be quite a delay, 10, 15, 20 seconds. So it's really important when you do the test that you actually wait a good 30 seconds before you sit up, because there can be a delay. And what's happening is, as the person lays back, as that debris rolls or moves through the canal, in this case the posterior canal, it will stimulate the sensation of vertigo or spinning. And if you're lucky and you look at the person's eyes, you might see the person's eyes flick or rotate, which is called nystagmus. And this is to do with something called the vestibular ocular reflex, which connects your eyes and your ears together. And when there's debris moving through the inner ear, often the eyes are moving. Sometimes the flickering of the eyes or the nystagmus is so quick or so fine, the observer will not be able to see it, but the client who's being tested will definitely know. They'll have a sensation of either spinning or movement, or they'll feel that their vision is blurry or going double. But if you wait, again, for a good 30 seconds or longer until it stops, generally the symptoms should stop. And that's basically once the debris stops moving through the canal, then they're fine. Then once that happens, you sit them up, and then you repeat on the exact opposite side. And most of the time, you're going to find that the symptoms will only be in one ear. Okay, rarely will you see it in both ears. But again, that's where you need a physiotherapist who's experienced with treating vestibular systems to be able to determine if it's bilateral. Most of the time, it's going to be posterior canal, but occasionally, rarely, other canals can be involved, particularly the horizontal canal. So again, a concussion therapist who has vestibular training will be able to test these out and determine if that's the case. Now, treatment for BPV is very effective if that's what you're treating. And the Dix-Hallpike test that we just described is actually the first step of the treatment. So if you lay the person down on the right side and they report nothing, you sit them up, you lay them down the left side, and within seconds they go, oh, I feel a bit strange, things are moving, I feel a bit dizzy, and you wait, and then after 10, 15, 20 seconds, they go, oh, okay, it's stopped now. Then we've got a positive for left BPV there. So then we'll go into treatment, and basically from the sitting up position for the left side, they turn their head left, you lay them down, wait 20 to 30 seconds, then slowly rotate the head to the opposite side, with the head still tilted back 20 degrees. Again, you wait 20 to 30 seconds or longer until any symptoms of dizziness, spinning stop. Then you roll them over to the opposite side, keeping their head tilted down about 20 degrees. And again, wait 20 to 30 seconds or until all symptoms of dizziness, nausea, spinning, what have you, stop. And then you slowly sit them up. And when you sit the person up, some people will feel quite dizzy and some people have nothing. So everybody's different. As you roll the person through those different positions, some people have no dizziness at all, and some people in one or two of the positions will be quite dizzy for a few seconds or longer until everything stops moving. Once the person sits up, We usually advise them for the rest of the day to try and reduce their activities. We don't want them moving their head around, shaking, bending their head over. And usually that night would advise them to try and not sleep on the side that was treated and sleep with 2 or 3 pillows to keep the head upright. Just trying to minimize the chance that any debris that's been removed from the semicircular canal doesn't fall back into the canal overnight. The client is usually then taught how to self-treat themselves at home, doing that same maneuver over 1 or 2 pillows, and then the next morning they can test themselves, and if they're still positive, they can go ahead and treat themselves if they feel confident. Otherwise, the physiotherapist will probably get them back 3 to 5 days later to review and determine if the symptoms have gone. And BPV, the stats are 80% of treatments first time will resolve symptoms. So it's extremely effective treatment if that is what's there. So that's the most common problem you'll find after a concussion, head injury, minor head injury, will be the BPV symptoms. But again, not that common, maybe 10% of all concussions that we see. If there's something more serious going on, for instance, if the person's had a skull fracture through the semicircular canals or the inner ear, then we're looking at something that's not going to be nearly as easily fixed like BPV, and will involve a lot of training for what we call vestibular rehab, which is a lot of balance exercises. And what we're trying to do there is basically retrain the brain to try and compensate for the fact that the vestibular apparatus isn't working as effectively as it used to. And that sort of training can take weeks and probably months before the person can regain their balance and feel confident again. Is vision and how it ties in with concussion. Vision has a huge impact after concussion. About 70 to 80% of your brain is involved in interpreting what you see. And so as a result of a head injury concussion, a lot of people will report some sort of symptoms that are related to their vision. All right, so this problem that we're talking about with the vision, there's actually generally there's no injury to the eye itself. The eye is functioning properly. It's the actual ability of the brain to interpret what the eye is seeing that becomes the issue. So a lot of people who have had a concussion notice that they've got double vision or blurry vision, having trouble reading, and they'll go and see an optometrist and they'll do their eye tests, and they're checking for something called acuity, which is the ability to see something clearly, and they'll be told that there's nothing wrong, that everything's fine, and yet the person is still having problems with double vision, blurriness, that sort of thing. And that's because, as I said, there's actually nothing wrong physically with the eye. The eye is working properly. It's just the brain's having difficulty interpreting what we see. Common symptoms that people will be reporting if they've got visual issues is light sensitivity. A lot of people after head injury concussion are very sensitive to bright light. They also have problems with using a cell phone. Scrolling through a cell phone is particularly irritating for some people. They got limited tolerance or time being able to watch TV. Some people will report that fast action movements sort of on TV are quite irritating for them. They got reduced tolerance for reading. They find that they just can't concentrate. They get very tired. It gives them a headache. It makes them feel sick. Driving is another one where vision is very important. You need to be able to judge distance and speed. You also have to have very good peripheral vision to be aware of what's going on around you. And so a lot of people after concussion will note that driving is difficult, and they will self-limit themselves and avoid driving for a while just because they don't feel comfortable. If people are out doing things, driving, and they're not aware of their peripheral vision, there's a high risk of accidents at intersections of that because they're just unaware of what's going on around them. So it is an important thing to be checked out. Then another interesting thing with vision is supermarket aisles and shopping in places like Countdown, Pack and Save, or going to Mitre 10. Some people have visual irritation sensitivity. They cannot tolerate going down an aisle. It just overwhelms them. And we feel that's because of the visual stimulus. There's lots of bright lights, the depth perception looking down the aisle, and all down the side of the aisles there's lots of bright coloured products. The person is constantly moving their head and eyes and scanning to looking at everything, and if they've got a visual problem, that will often make people feel very unwell. So vision definitely needs to be assessed. Physiotherapists who are trained to do this can do a pretty good job. We can certainly get the basics done and determine whether there is some visual sensitivity. Then we can also start doing some treatment or exercises. But if we suspect that there's something more serious going on, or the person's not responding to treatment, then a common recommendation for a physiotherapist would be to refer you or the client on to see a behavioural optometrist, who are a little different than your general optometrist. They, as I mentioned before, are looking at the function, how the brain is interpreting what you see, and they do various tests with glasses using prisms and different tints, etc., to try and alter what's going in through the eyes and see if they can settle people's symptoms down. So that's an option that physiotherapists will consider if there's significant symptoms with vision or they're not responding to treatment. So when the physiotherapist is assessing vision, we are basically just looking to make sure the eyes are centered in the middle of the head, make sure your pupils are equal size, and then we'll do some various testing movements to see how the brain and the eye is functioning. One of the first tests we do is something called pursuit or tracking, where you get the person to watch a finger as it moves from left to right in like a big giant capital H, and then some diagonals. What we're looking for is that the eyes should both move together and be nice and smooth, and no symptoms. So what we may see is people are struggling to follow the finger, or it's quite jerky, or you can see the person is just not tolerating it well. And when you ask the client how they feel, they might say, oh, that makes me feel quite sick or unwell. And they might even be quite specific, like, oh, every time I look up to the left, it makes me feel unwell. So that's pursuit tracking that we're looking at. Then something else we'd then look at is called vergence. That's the ability to bring your eyes in together, teaming them together, like if you're reading a book. And that involves having a object placed about 60 centimeters away from their nose, bringing it slowly in towards their nose and seeing if it goes double. Now, for the normal population, it won't go double until they get within about 10 centimeters of your nose, which is very close. So if the person's saying that the object's going double at 20, 30 centimeters away from their nose, then that's telling us that they're having trouble bringing their eyes together and keeping them together to look at something in front of them, which obviously is important for reading. Then we'll look at something called saccades, and that's the ability to flick your eyes from side to side or up and down. And in my experience, this is quite a useful test to do, and a lot of people have trouble with this. It's very important when you're reading, when you think that you scan across the page, then flick your eyes back to the opposite side and scan across and flick back. So saccades is going to affect people's ability to read, a book or a computer. Also, if you're driving, you need to be able to flick your eyes from side to side without having to move your head. And so if you're having trouble with that, then it's going to be quite symptom provoking. So the test we do is get a person to fixate on object in front of them, and then we have another object like our hand, finger, about 30 centimeters to one side, and get them to flick their eyes from center to side and back. Then we get them to do that rapidly about 10 times. And if you have had no head injuries and vision and brain are working fine, you should have no problems. You should be able to flick your eyes backwards and forwards quite comfortably at a good speed 10 times. And what we tend to see is if you're having issues with this, you struggle. They can't do it. They can only do it really slowly, or they can only tolerate it doing it 4 or 5 times in one direction, and then they'll say that it just makes me feel unwell. So that's the saccades testing. Then there are a couple other specific tests that we do for the vestibular ocular reflex. One of them involves fixating and looking the examiner's face or their nose where they're sitting in front of them, and then getting the client to shake their head from side to side. They should be able to hold their eyes fixed on the person's face or nose without too much difficulty. And then the physiotherapy examiner will do a quick flick of the head to one side and bring them back. And if your vision's going well and your vestibular ocular reflex is working well, you should be able to keep your eyes fixated on the middle of the person's face, their nose, without losing contact. If you get a positive test, what you'll see is the eyes will basically slip and they'll just move away, and then there'll be a few seconds before they come back to the middle again. In other words, the vision and the vestibular system are not working together. They're not able to maintain that that centered gaze. So another important test that we do. So after we've done some of those visual tests, and there are actually a lot of them, that's just a couple of the basic ones that I'll tend to do, then we will then devise some treatment around treating the vision, and it's usually something called habituation, and basically it's a matter of doing the activity that you're having trouble with over and over until you get used to it. So it's sort of like training for a sports event. For instance, like a marathon. If you were to decide that you want to go and run a marathon, most of us, there's no way we're going to be able to do it today. Even if we started doing a little bit of jogging and walking over the next week, there's no way we're going to be able to do it in a week's time. If we started training seriously and had a nice little program, even after maybe 2 or 3 months, most of us would not be able to do run a marathon. We just need more time to build up our tolerance. If I was to say to someone that we've got 12 months to build up your tolerance so that you're fit enough, strong enough, and could tolerate actually completing a marathon, majority of us would be able to do that after 12 months of training. And so that's habituation. That's why we train. We need to give our body time. In the case of running a marathon, our muscles need to get stronger, our joints and ligaments and tendons need to be able to tolerate the forces of running. Our cardiovascular system needs to get stronger so we can keep running. And it takes time. It's not something that happens overnight or even a week or two. And it's the same with the vision. We need time. You're relying on something called neuroplasticity, which is the ability for the brain to adapt and change and make new pathways. And that takes time. So when we're doing the visual retraining, and also, as I mentioned earlier with the vestibular stuff, if you've had some serious injury like fractures through the inner ear and we do vestibular training, we're basically trying to retrain the brain to learn new pathways, rely on the neuroplasticity that occurs to allow the brain to adapt, use other strategies, other pathways to compensate for issues with vision or vestibular deficiencies, and learn to cope and be able to move on and keep active. But it does take time.
Thank you so much for talking to me today, Steve. I've learned a lot, and I'm sure our viewers have too. Steve's provided me with a list of websites with more information about the topics he's spoken about today. They'll flick up at the end of the interview, so please jot them down and head over and have a look at those sites. Thank you for joining us today. Thanks again, Steve, and please tune in for our next interview.